Well, good morning, everyone.
Good morning.
Thank you for having me again. It's good to be here. As usually. So we're ready to get started. So I do have one or two little capsules of things we could talk about, which would require for me to plug in my computer to show something. But it's so much fun when we have the conversations and the Q&A. So I thought we could start with that. And if after 20, 30 minutes, we want to look at something else, we can then do that. Or otherwise, we could just spend the whole 50 minutes in a Q&A kind of conversation. So totally up to you.
I'm not worried about your grants.
I'm worried about NIH generally, but in all of that.
Yeah. Well, there's about 100 millions of us that are equally working. I don't know what the other 100 million is doing, or thinking, but yeah, it's a problem. It's a real problem. And it's at many levels. So the main problem is these are institutions that usually move slowly for things, and because they're large and it takes a lot of culture and a lot of people to kind of change mindsets to make changes. And suddenly the whole entire thing has been flipped upside down, right side up. And so the shock of it is problem number one. Problem number two is the uncertainty, because no one knows where we're going to land. And so are we preparing for where we're going to land with whatever the changes are? And no one knows the answer to that because no one knows where we're going to land. So no one can prepare for what's coming because no one really knows what's coming. And that's the other part of the problem here. There's no planning here. And if there is a plan, they've never told anyone. So that's how I say there's no plan, because I would have expected that if they have a plan, they would tell us, but they haven't. No one's told us a plan. So what they've done is they shut down, the NIH shut down, they stopped paying everything, they close all the websites, and now slowly things are starting to open up. And now slowly we're getting dates for meetings, and slowly people are starting to answer emails from the NIH. They're rescheduling things, but then there's some things that are not being rescheduled, some things that are just been told, that's it, no more, you're not getting any more of your money. There are other things we're learning is you're not going to get any more. There's no more. So the NIH works by calls. They put a call on a website. We read the call, and if it's something that fits our research, then we start working on an application. So there are lots of calls that disappear. So things people thought they were going to write for in June and October and next year, planning for that. Now when they go in, there's no longer a call. So there's nothing to write. No way, no channel to apply for new funding. The other big thing that they've done is they're eliminating or changing the amount of money that the NIH provides the institutions. And so this is something most people in the community don't know. When I write a grant to the NIH, roughly about half of the money comes to us in the laboratory or in the program to actually put into the science and the research. And roughly about the other half of the money goes to the university itself. As a way of supporting, this is so-called indirects, to support the infrastructure, because I can't do my research in my garage. Although Bill Gates got away with that, but the rest of us cannot. So we need an institution with a huge amount of effort and infrastructure to do that, and so that's what those funds go to. Well, they eliminated those, or they're cut down. They're renegotiating. The problem I have with it is that if they were to say, okay, starting next grant, you are going to go from 50% down to 20% or 10%, whatever the percentage is, you can plan for that. What they did is like, we're no longer going to give you what we said we were going to give you anyway. So to me, it's a breach of contract. I'm not sure why is it that no one is suing them for that. I guess because they are the ones that make the contract, pay the contract, do the contract, and the one that handles the lawsuits too. So it's a little bit of a conflict of interest, but in simple terms, it's a breach of contract. You sign a contract for 5 years to do this project, and now you're not going to pay anything in some of them. In other ones is we'll continue paying you your directs, but not your indirects, which creates tension then inside of the university on how the university is going to handle that. So now we have problems with the NIH, unpredictability, the lack of funds. Problems in the university, like how do we pay for the electricity and the employees and the computers, and all this other, and the parking and all this other stuff that is requiring infrastructure for us to do that. So so there's just now has become so many fronts in which there's uncertainty to you. And on top of that, I still got to finish my research study, my science, like that. So yeah, so it's become really challenging and simply stressful to do more than suddenly we're not used to doing. So what I did personally, I immediately shifted our efforts from grants to the NIH to put grants to another institution, the American Heart Association. And they had like 4 things that were open at the moment. So I basically, since January, scrambled to turn the ideas and projects we have and rewrite them slightly differently for a different funder. And so far I'm 0 for 5. So it's going to take a little bit of time before I usually average about 1 every 9 or 10. But because I know that I pace myself, I spread out the collaboration, so I have a strategic planning for that. I'm a little worried that it's gonna take a while, like 10 or 15, before I get the first one outside of the NIH, Nick. So, yeah. So to your question, yes, it's very challenging to live in this world of research.
Private sector grants available?
Yeah, they are. They're usually much smaller grants, much shorter, much smaller than the NIH. Sometimes they're a little easier to get, but they tend to be smaller and shorter, which is kind of a nice balance. But when there's such a large deficit, then now those grants become much harder to get, because guess what everyone else did? They all sat down and say, oh, the HA has this open, I'm going to write for that. So now the competition is like, when you create a resource, you make a resource scarce or not available, then everybody fights a little harder for it. So it's a harder fight for the available grants until the new normals set up, reset. Yeah. One comment before. So the National Science Foundation, which is the other part of the government that funds research other than the NIH, so the National Institute of Health funds all the research related to health, to promote health. NSF funds other research other than health. They do fund biological research that could be used for health. But if you tell them you're doing it for health, they'll kick you out to the NIH. You just have to say it's for biology, it's for the good of humanity. And, because we need to understand these things, it could still be health related, but just kind of the focus has to be for the sake of science. But then they do everything else, engineering and math and all this other stuff. They had lots of their grants just shut down completely, period, no questions asked. I mean, like even worse than the NIH. So just 2 days ago, the group of foundations got together, and large foundations got together and created a consortium to try to buffer the impact to, because this means when I say grants, the largest number in my grants is the salary for people who are working. So when the grant goes away, I have to let people go. So we already let 4 people go in one of our programs because we have no more money and there's no more expectations of the money's coming. So this creates an impact on employment of scientists or people having to shift careers or retire or so, because there's no stream. But anyway, this group of foundations put together a small award opportunity for $25,000. So if you can tell them that your grant got shut down or canceled or cut or something as part of your application, then they'll award up to $25,000 so people, even though they may have to be let go, they at least have 3 or 4 months, 5 months to plan for being let go. With that 25K, you can kind of still pay people for a few more months, or finish your analyses, or finish the last experiment you needed, so you can get your science out or something. So it's really kind of a bridge support. And so private foundations are trying what they can to try to ease the tension. Yes.
Is there anything that we have to take hardworking American person can do?
Yeah, so I have a 3-point plan for when I get asked this question. Point number 1, vote on the midterm elections. what is in your mind, whatever it is. Number two, ask your congressperson to support the science, because sleepy Congress is still asleep. And so we need to somehow wake up sleepy Congress to do something about things. And third is ask who else is funding the work that I care about, and ask questions of philanthropy. Where can I help? And I get patients who donate $20 to my research, and I love it. It's really, it opens the door for me to have a different conversation in the office than the what's your chest pain like. And we offer to take people to the lab. We offer to meet separately with them and just show them the research we do, show them what we invest our efforts on and those monies on and whatnot. And so I run a lot of my a lot of my small educational programs I do in my research. Like I need to, when I get 20 students in a room and talk to them about science, I got to get them lunch. So, that $200 lunch comes from, these gifts. And so it allows me to support some of the loose ends of that. Obviously, to support the research itself, it has to be a much bigger donation. But that's the other thing, that as an individual, you can start thinking, who is doing or what kind of work is that I would want to be able to support. And I don't know anyone that today wouldn't say thank you in a big way for that. So
Also volunteer at cancer research thrift store.
mhm.
Cancer research.
Yeah, the Biden administration made an investment, a huge amount of investment in cancer. It was one of the things they wanted to promote. And so a lot of that is being, started and then pulled the plug on. So yeah, they're noticing a big difference. Yeah.
I just don't. Do you see sense whether it's that we don't like science or targeting specific types of science? Can you tell anything from speaking with your colleagues about
why the administration's cutting off the money?
Yeah, well, first, it's specific areas that, and you're noticing, this area is flourishing, but they're taking money.
Yeah. It's pretty scary what they're doing. And we're never going to know any official statements because they don't tell us what they're doing. But I can tell you what people are chatting, the scientists that I know are chatting about. And some of it we're already noticing effects of. So they don't like certain words. They don't like diversity. So what do? They ask Elon Musk and his 7 dwarfs to run AI software through every brand that's ever written that has the word diversity in it. And that went to the top of the list of axing. Is that rational? So no, I cannot tell you that there's any rationale behind it. It's just their mode operandi of what they're doing.
Something like the recent changes in how they calculate EGFR and other diversity related.
That's right.
Can you repeat the questions?
Yeah. So the question is, is there rationale, or are they doing something in a systematic way, or focus on specific things in terms of the changes they're doing? That's one. And then the last comment is that I made is diversity is a key word, and there are others. It's not the only one, that they're trying to eliminate anything related to that because they no longer value the element of diversity. And that's a very interesting conversation that we could have separately about what's happening right now. But whether you value it or not, personally, you cannot get rid of what it is. We're a diverse country. And so when you eliminate the concept of diversity at the expense of eliminating the things that takes care or addresses the deficiencies of certain of us, then you're denying even the existence of certain of us. And so it's really confusing very fast why you're doing that. And so there, again, we can talk for a long time. The one thing that I've seen, and so diversity and equity are interesting concepts. Equity is a concept of saying if you have diverse needs, you create different approaches for different folks that have different needs, but at the end you want to try to bring them all up to kind of the same healthy level. So some of us may be down here, some of us may be up here, if you think of it as a coin just going up. And so this may only need a little bit to get here, and this may need a lot to get here. But the equity means that we try to bring everyone to a reasonable upper level. Cutting Medi-Cal funding is a way of saying we don't care for equity, because we don't care that the people who are at the low end of income and social economics get their mammograms and get their colonoscopies and get their flu shots we don't care about that. Let them get the flu. So be it. Let them get their cancer. Because that's what that does. It's prevention, right? It keeps people from getting either A, getting the disease, or B, capturing early enough that they can do well from the test. But if you have good health insurance, guess what? You're going to get maybe even an extra colonoscopy every so often, and maybe a little, I don't go to the mammograms thing because my wife is a mammographer, so I got to be careful what I say. That's the problem. The problem is that you have now decided that some people are more valuable. That's the complete opposite of equity. So initially we were afraid that equity was the other word that we're going to use, and there was some noise about that, but we're starting to see that some programs, so if you're not trying to promote diversity, but you are trying to promote equity, we're seeing that some of those grants actually are not being cut. So again, is there a rationale here? Maybe there's some rationale behind all of this. We don't know what it is because they haven't told us. We just see kind of the output that comes on the other end. Gender issues is another one that they have just gone, and any buzzword of gender issues across, they just want to cut it indiscriminatory. So certain groups and certain concepts and certain needs, or groups with needs, or certain diseases are going to be basically looted and devastated from what they're doing. Still not sure who's going to be the winners. I don't know who the winners are. I don't know what they want in health. I mean, what is it that they want? What disease do they want to try to help us with? We have the worst epidemic of measles in the last 30 years in this country. Measles was eradicated from this country. I don't know if you know that. We eradicated measles. There were no other than a spontaneous case that never turned into anything else. There was no contact epidemic type of level of measles. And we have 800, 900,000 cases currently in the country. We've had 2 kids who die already. I mean, 20% of these, mostly kids, get hospitalized. Now they have to spend a week or 2 in the hospital. None of that was happening. I'm not saying our government is doing that, by the way, but there's a lot of people that don't believe in vaccines, and our government doesn't seem to want to support the idea that vaccines are a way of preventing diseases. And so because they don't want to defend that, then it opens the door for the people who believe vaccines are not good for you. And then we have our new Secretary of Health going around and telling everyone the vaccines are bad for you. And so when you say that, combined with people's own personal feelings, and now the government's telling me on top of that it's bad for me, I believe the government. So then why should I not? Because they want our well-being. They must be protecting us from a bad thing. So I'm not going to take my vaccine. So we'll see. Keep an eye on measles. Measles is kind of the canary in the coal mine when it comes to vaccines and what would happen in the future with that. So back to my 3 points. Only focus on the first 2 the most. Make sure you vote on the midterms, and make sure you contact somebody and tell them that you don't like what's happening with the NIH and the science and the health programs in the country, so they know what their constituents stand for. which helps them kind of decide whether they're going to vote this or that way, because they fear that you're not going to vote for them if they go against what you want. So I mean, it's connected to the point one and point two are connected to each other at two different levels. Yes.
It's a country issue. Not only for health science. Terms they don't like. Things like preservation. These were wasting a lot of resources. Parts. And so.
Mhm.
These things of that.
To developers yeah. So I am an ignorant person when it comes to climate. I know climate is a problem, and I don't want to stand here and say I know anything beyond anyone else about this. So when I speak about anything other than medicine and health, I'm speaking just as the next person sitting next to you. So just want to make sure I put that full disclaimer out there. But the one thing that bothered me, so I pay attention to a lot of hurricanes because I'm from Puerto Rico, grew up with hurricanes. My family gets affected by hurricanes. So I care about hurricanes. That's who I am. And so I learned that they're no longer going to quantitate the damage of hurricanes to the country. I mean, they put out they created a threshold. So if the damage is bigger than $1 billion, they're not going to report it. So now we could have a hurricane that destroys more than anybody else or anything else in the past, and it's $10 billion to Florida. We're never going to know about it. So we're not going to be able to tell that this hurricane in fact impact the country more or less than the next one, because they're going to start eliminating the data for this. So we're going to become less knowledgeable of what affects us the most. Fires, give me an example as well, hurricanes. So how and where in school did they tell you that becoming less knowledgeable about something somehow prepare you better to take care of it or handle it? Again, is there a rationale to your question? Is there a rationale behind this? There's no rational thinking, I think. Because knowing less doesn't really help us understand better a problem. So, and you're right, it's beyond health, it's climate, it's other items. I'm sure you guys can point others that don't come to my mind at this moment. So we're being impacted.
Delete the subject.
Huh?
Delete the subject.
Yes.
What about Aggie Square? Okay.
Yeah, Aggie Square is a very interesting. Aggie Square is one of the most interesting and ambitious projects I've ever seen in any one medical center I've ever been to. It's a juncture between the city of Sacramento and the university to build up in a larger conceptual way and physical way the campus in Sacramento. And it's a collaboration between industry, the city, and UC Davis. And it is intended to bring a footprint of the undergraduate colleges in Davis to the Sacramento campus as well. So there's like a half a dozen goals and stakeholders there. So there are these large buildings that are now almost open. They're going to be occupied by researchers in part. They're going to be teaching educational centers, classrooms. There's actually some housing. And I've heard different numbers, but roughly about half of the space is going to be leased out to companies and business and industry for them to come and collaborate in the same buildings as the scientists and the researchers and the healthcare providers. So it's really intended to create this very vibrant environment for research and for development of technology and many other things to come up.
Where is it?
It's right next door. It's like 2 blocks from the hospital. I know if you're in Stockton and you're looking right at the hospital here, there's a block. There's the Glass Rock clinics. Then there's the cancer center kind of entry point. And then there was a parking lot, a huge parking lot, like 2 or 3 blocks of city blocks that was just a flat ground. And now there's 4 huge buildings in there. that they built in the last 2 years. And I am supposed to be going to a meeting in about 2 weeks where it's actually for me the first time to go to these meetings, where it's a small group of faculty who's going to start discussing the future ventures of Aggie Square. But I know there's been faculty for the last 5 years doing that to prepare to the opening. And so I guess I'm now joining the group that's going to go beyond the opening into the future to start exploring what that would look like. I'll tell you my personal fear is that NIH just got a lot of indirect funding that the university was counting on to support these buildings. And there'll be lots of scientists that will probably have their grants run out, just like we talked about in the last 20 minutes. So I'm worried that they're not going to be able to fill those buildings. They're going to have these big buildings and there'll be some empty room for a long time. But that's to be seen. That's my personal opinion. I don't know anything specific about the university about that. But it is my fear that that may be what turns out for the next couple of years. A lot of beautiful buildings with empty space. Unless something else changes. Because I know that there was a huge investment on the concept that people moving in need to be the people who move in. People who move in first have to be the people who have grant funding for the reason that they bring their indirects to support those buildings. If that number shrinks down, number one, as number of investigators, but even if you have the same number of investigators, their amount shrinks down because the NIH is not giving them much now for indirects, then the university is going to get a lot less supporting money for the infrastructure that they just built. My understanding is that is the single biggest investment Sacramento City has ever made in any project, any structural project to build in the city. And it was a partnership between the University of California and Sacramento. But it was like the largest development project they ever have built. So it's pretty big in conceptual for the city and in construction for the city. So, and it's supposed to develop work and employment for people in the neighborhood. And there's some criteria that they have to hire so many people that live in the area, in the neighborhood, to try to bring employment and improve the social economics around the center. So there are a lot of interesting good things about it. Just kind of scary time to have such a big thing, in my opinion, again, kind of a big thing in a scary time. Hopefully that answered your question.
Yeah, it's something I've seen being in emeritus. I get these things periodically, counting quantity of space, and I get a shiny picture, and it's okay, but there was a picture of a bunch of people in a shovel, and then recently a bunch of people cutting a ribbon. So
Yeah.
and so it's like, okay, but I don't know how that. I saw a lot of community involved. I think about it, the system, the health system of the whole UC. Are they looking at this as a model for implementation in any of the other hospitals in the system? What is the larger context? And I think it sounds like we're still too early to know, and there's a bump in the road at the moment. So.
Yeah, the bump on the road is just my personal perspective. I think the university is really just gung-ho to get this up and running, and they're very proud of it. It's a great investment for the city and for UC Davis. If you compare to UC San Francisco, this is probably still a smaller project than other UCs have handled, because UC San Francisco did the whole Mission Bay campus, which is blocks and blocks and blocks of buildings and development like what we're having here in Sacramento. So in a way, we're catching up to perhaps the magnitude of things that happen in San Francisco. So in terms of being a model for other UCs, I think this is a model that they have embraced in other UCs to kind of invest in the city development as part of expansion of the university.
Your dream list that you would have a lab in this facility, or?
My dream list would be that we would have a exercise lab for studying, all the variations that we can on physical activity and exercise that could improve people's cardiovascular. and that it would be a place for incubator where we bring technology, bring companies that have devices and metrics and there are all kinds of ways of doing exercise, not just a new step and elliptical and a treadmill. There are lots of other ways, and a lot of them can be exercise, should be still tested in terms of what the benefit is to people. And so there's still a lot of room to evaluate ways of exercise and then ways to evaluate the performance of the average patient and supporting the improvement in performance of the average patient. So there's still a lot of research in that space. So if you were to ask me, we would have a exercise lab next to a gym for providing care. So we could run a clinical trial where people can just walk across here and then do all their research testing and then go back out there and continue their treatment intervention. So it will be kind of in the same place, have the ability to treat patients in a clinical setting as well as testing patients. And so that way we break a lot of barriers to doing research today at UC Davis in this context, and put it in a single place. And then once you build that, then you can attract industry to come and see, okay, well, we got the perfect setting to do your drug trial, your biological sampling, your biometrics, and the testing all in the one infrastructure. And that should bring investment from industry as well as other grants.
Help us to arrive in that now.
Yeah, that's right. I'm not losing any sleep right now about it.
I always have. So I know that coming here is probably the most important thing, but is there any other thing that you could suggest for protecting our parks at this time through this stuff?
Yes. The question is, there are lots of things happening, but what can I recommend to protect our hearts and our health in these times? And I think there's some simple things that you should be thinking about and could think about if you're not already thinking about them. And I've talked of some of them before. I think there are risk factors to your health that are socially related. And I think it's important to not ignore those. So smoking is bad for you. So if you're smoking, please, let's have a conversation about how we can help you to stop smoking but we've been saying that since the 1970s. So what's newer to consider? I think we talked about before about loneliness, social isolation and loneliness. So programs like this help address that. And I can't say that enough times to say, because there's even people present here who may still feel lonely. So loneliness is not just a physical next to others, but it is somewhat of a complex concept of interactions with others and feeling like you are actually part of something and part with others of something. That's incredibly important. It's kind of a new risk factor to cardiovascular disease. So addressing that as a group, as a community, it's important. We talked about mindfulness before, and I think mindfulness sometimes gets undercut of many things. Exercising is good, eating healthier is good, quitting smoking is good. But being mindful, which many times is just allowing yourself to be focused on the moment. You don't have to work really hard for it. It's just kind of a mental program recognition that to be in the moment and not let all the noise of what's happening around us to really, really kind of occupy your space in your mind. And then taking care of your sleep. So sleep is the latest factor of consideration from the American Heart Association. In the last 4 years, have been promoting the idea that improving the health of the what did they call it? The quality of the sleep hygiene. That was the word I was looking for. The sleep hygiene. To focus on your sleep hygiene, which doesn't mean go and clean the bed a little stronger with bleach. It means eliminate all the distractions, the noise, the TV in the room, the coffee an hour before you go to bed. So it's thinking about all these things we can do to actually favor that you do get your 7 hours of sleep. And if you're not getting 7 hours of sleep, then ask questions about how you can improve that, because just like loneliness, mindfulness, sleep, all of these things are things in the present you could be, if there are issues with those, that you could be addressing and asking questions how to address better And all of them are going to favor that you stay healthy and more resilient over what, with what's going on today. And then, of course, take your medicines, get your blood pressure under control, get your glucose under control, the usual things that we've talked before. But in terms of new things to consider, that's what comes to mind. That's in one hand. And I'm going to want to kind of say something on the other hand of this. It's called health anxiety. And health anxiety is actually somewhat of a new concept to me. And I'll share it with you. So it's the idea that because we hear so much about how to be healthy in this and that, we actually start worrying a little too much about our health. And now we fit into an anxiety pattern. Do I really have cancer? Do I have cancer? Did that test really eliminated the possibility that I have cancer? I must have a cancer. And in this sense, I'll share a personal experience with my father, who continues to struggle with this. And for the last 5 years, he's been on the quest for cancer, that he has cancer, and he has an autoimmune condition, which could very well be this first symptom of cancer. And once he got that in his mind, he's gone to every doctor in Puerto Rico. He's had about 17 CT scans of every part of his body. I think he's had like 4 colonoscopies in 6 years. It's just really, and I talk to him about this all the time, and I think I've made some progress trying to eliminate this anxiety, put at ease this anxiety. And then the next thing I know, he's in the next specialist, having the next. And I said, Dad, every time you walk in the door of a doctor, you complain about something, guarantee you'll walk away with a test. Please do not complain. Go in there and have them check you, but don't complain. And it's like, it's got to go and say something bothers him. So it really is a kind of he has an excessive amount of anxiety about the fear that he's going to die with cancer. It's his personal fear. And what that does, it creates the anxiety of constantly feel as if he's been deceived by others. Like everybody's kind of like trying to keep him from knowing. And you can see that this at some point becomes unhealthy. So I use that example because I'm living it as a son, as a family member who's going through this. But this has actually a public health issue in terms of added stress to our lives, which not directly, but in some way will affect your wellness because you're so focused on the anxiety around this. So not trusting, after you've had the tests and you have had the discussion about how good is the test and how much to still want it, more tests, and all the tests continue to line up. At some point, all the tests line up negative. At some point, we're being driven by anxiety, not by actually concern. So it's like kind of the concern over your health and anxiety over your health is somewhat in a continuum. And so when do you cross from one to the other is somewhat of a personal thing. But I would just plant the seed on your mind to ask the question, am I just being overly anxious over this? Or am I really do need to keep going and get that other CAT scan and that other PET scan and everything keeps coming back negative, but I must have something in there. And I have to be honest with you, there are moments where you have to advocate for yourself to make sure that we've gone to the bottom of things as far as we can. So I'm not making a blank statement here at all. But there's also there's a percent of people that are still been driven by the anxiety without any true basis in health. And this is an important conversation to have with your doctor, obviously, and others with the pertinence of yourself, with your details. But I just open it up there. It's estimated that about 10 to 12% of the patients we see in the office, the reason we're seeing them is because of their anxiety, period, not because there's any condition. And so that's, I see 25, we see in a half-day clinic, we see 25, 30 patients. So that means 3 of them are being seen just because of anxiety. So, or this so-called health anxiety over health.
But your hope is that you're seeing when you're relieving something.
So we're supposed to do that. We actually see it in cardiac rehab. We put the monitor on them for EKG, which is supposed to be able to allow us to tell them your EKGs are fine when you exercise. You don't need this. But the moment we try to take it away, people freak out. Like, no, put it back. I thought, what do you mean? What do you mean if something happens? You've already exercised 20 times with us and never had a single thing happen to you. We haven't seen anything abnormal. In fact, you're doing great. You're feeling better, this and that. you don't need this monitor. And it, they just, there's panic in their eyes, you know, about the monitor. So sometimes same thing happens with hypertension and blood pressures. We've been doing this program where we give blood pressure machines to people to take home, and we say, measure your blood pressure once or twice a day. We give them actually a calendar with the times. Then we say, measure it 3 times, sit down for 5 minutes, take 3 readings, 1 minute apart, and that's it. And then we look at our dashboard, 18 measurements in 1 hour. What was that for? You know? And it's like, we got these where it's like, it's high, and then they just keep pushing to document that's high. And then when we talk to them, it's like, well, I thought it would go down after this 8th time that it's still high. It's like, no, we gotta stop at 3 and make a call. Let us know, send us a message. So really, when we get empowered, you know, we all need to be empowered, because if you're powerless about your situation, then you are anxious about it. We need to be empowered. But once we have that power, then we need to consider the idea of how much of that do we execute such that we don't fit into an anxious state of mind.
There is a question in the chat. From
Yes.
Yeah, so what is the new UC Davis Medical Building on Highway 50 in Folsom to be used for?
So they are building new clinics with new services, they're all clinical services for the most part. In Folsom, there was one in Elk Grove that I think was done already. There are a number of them. There are 2 or 3 that are still in the works right now. These are just expansion of clinical space for different programs. So I don't know the specifics of what kind of clinics they're going to have there, but it is expansion of clinical space.
And that's where Dr. Buka Putnam currently works, right?
That's right. I think she now works over there. Yeah.
She'll be her birthday, we can ask her.
Yeah. Yeah. And you know, UC Davis is building a new hospital altogether. I don't know if you know that. So
That's the double tower thing or something?
yeah, so it's gonna be 14 floors. I think it's 14 floors. It's gonna have a double helicopter thing in the top, and it's gonna have like 400 rooms, if I understand correctly, and every room will be capable to be converted into essentially an intensive care room. So I was not part of any of the planning of this, so none of what I'm saying is officially UC Davis anything. But my understanding was that they wanted to have a hospital that could handle any mass casualty or problem that occur. And this is fueled in part by COVID, in the beginning of COVID, where we had massive amounts of people in the emergency room, massive amounts of death happening from COVID, and no one knew exactly at the time the when this was going to end, and whether this is going to have to persist for a long time or not. And thank God it did not, and wind down thanks to vaccines for the most part.
So construction started on that.
I think the planning for the considerations were even before COVID. I think the fact that we had COVID helped people change their votes on voting for doing this. But it's going to take another 8 to 10 years to build. So they already built the parking lots around it, which is the first thing they wanted to do, is have enough parking lot to make sure that people coming in and out of this new had a place to go. So building parking lots and other things are in place already. And now they're going to start building the actual tower for this, but it's going to take a remarkable amount of time to build. Yeah, you had a question.
You see all these buildings coming up, more space, more services, more research and such. What about it seems there's a shortage of new doctors coming, new nurses to add to what we have, so that people don't get fried working.
Yeah.
Multiple shifts. Long hours.
Yeah, no, that's a great point.
What's
The great point is that we see a lot of buildings and a lot of clinics being built, but is there a need for new doctors and new nurses and new other staff to fill these spaces and provide more services and not burn out, or not quote unquote get fried, which is a burnout concept. Doing so much more work for every doctor. And yeah, that's the amount of graduates from medical school, while it has increased over decades, it hasn't increased very much. And definitely not enough to cover. There is a shortage of doctors. There is a shortage of certain specialists, which was quite affected by COVID again, because a lot of people retire early or decided to get out of practice with it. So there was a efflux of people from the profession. And I don't know that we have yet recovered from that. So you're correct about that. It's really interesting how medical school is so expensive that you can't just simply double your medical school class. It just takes a lot of investment financially to have additional slots in the medical school. And so it's usually dressed as very costly to do that. But so it's a great point. At some point we'll have to reckon with that. Yes.
Are also the medical needs kind of receding as the baby boomers now are finishing up their lifespan?
Yes. My practice with 80 and 90-year-olds is expanding. People, and they're doing well with their heart. Actually, they have other problems, but they are actually, we got amazing procedures and treatments, and so people are living longer. So yes, there's a larger baby boomers and longer lifespan together. So yes, there is going to be an expansion of people with common chronic conditions.
But at the same time, it will drop once that population has gotten big.
Yeah. So well, you're probably talking about 30 years. I mean, there's going to take a good 20, because the baby boomers are going to live to, a lot of them, to 80s and 90s. This wave that we're entering now will probably last about 25 years, 30 years. And then what will come after will probably be a much, population-wise, we're not expanding anymore as much. Or so I'm told. I don't know the date on this, but I am told. So I think you can estimate that 25, 30 years down the road, there will be a shrinkage of the magnitude of patients coming through. Hopefully we'll get good enough with prevention that will get affected, that will have fewer patients per se.
At the same time, there are certain things we're picking up on that we didn't realize were medical red flags. I'm thinking about like the plastics. You know, that's just an example.
How did you know I love talking about the plastics? No, you really hit me where I like it. So new things, you're saying new things that we're learning about that are going to affect us in the future, as we probably get better with others in the present. And that's totally right. And microplastics, I think, is the most under-recognized risk factor, not only for heart disease, but many others. So this idea of what we get exposed in the environment is fairly new. It's, you know, we think our diseases came from genes, diseases came from poisons or something, or bacteria and viruses. But now we're learning that what we are exposed in our environment is actually also part of the diseases we have or get. And so I think the idea that stress and all psychosocial stress and others have already been well seated in our view of things. And so we're currently doing a lot of research how to handle that, and hence some of the comments I made about sleep and anxiety and loneliness and others. But what's going to come in the future is microplastic is probably one of the very first big ones that are going to come about, because they're not only everywhere, but they're expanding in quantity. And when now people are starting to look in the human body, we find it everywhere. I mean, it's in your arteries, it's in your brain, it's in your where they looked in the prostate, they looked in testicles, they looked in arteries. They're the ones that I know for sure published work, and that I'm sure they've looked in just about every other organ. And these microplastics are there; they don't belong there. So the question is, what are they doing? And now I'm going to digress for a second to come back to that. You know, what are they doing? In the 1950s and 60s, heart disease was the #1 killer, no questions asked. And people would just have a heart attack at age 55 and just die, period, done. Today, you have a heart attack at age 55, and for the most part, most people actually survive, and they're fairly well change lifestyle, exercise, do all the good things, take your medicines, you do really, really well. That wasn't true in the 1970s, 1980s. So learning that smoking was bad for us had a big impact. Learning that cholesterol was bad for us and coming up with medicines was good. So what I'm trying to say is that death rates from heart disease were going down and down into the 80s, the 1990s, the 2000s. We just kept getting better at understanding what to do. And then somewhere in the 2000s, we stopped getting better. But we kept getting better at cholesterol management and blood pressure management, and we kept getting better at quitting smoking, but it is stopped. And now it's starting to go like this. Just as it started going back up like this, and we get hit with COVID. So now we have the COVID thing, which, did this with us. And it's probably going to, re-normalize. So COVID is a big kind of thing in the middle there, but it's going back up again. So the question is why? And so we think it's stress. People think it's lifestyle stress and anxiety and depression and loneliness and all these things, which are the psychosocial things that we talked about. And we think it's that because we can measure those and we know those are here and real and whatnot. But what else could it be? In the meantime, so that's what's happening in the human and the heart and the survival. In the meantime, the amounts of microplastic in the 1950s and 60s was near zero in our water. And now we used to get bottles, right? Who remembers? Maybe somebody remembers at young age when bottles were changed in the front of the house. You got bottles delivered and bottles were sent back in glass. There's nothing in the glass that gets into your body. Anyway, there's usually nothing in the glass that gets into your body that harms you. But then we start switching to cartons and then to plastic. And now everything you drink is in a plastic bottle. Every plastic bottle you have ends up in some trash can and now it's in the ocean in some way or another. So now the waters in the oceans are full of microplastic. The water you put in your body is full of microplastic because it's in a bottled water, in a plastic bottle. And so your food containers are all plastic, right? Think about that. Your takeout food is all plastic. A lot of vendors are changing to cardboard and others. So that people are starting to become aware that we just become so dependent on plastics that now it gets where else it is. It's inside of your arteries, inside of your brain, and we still don't know exactly what it's doing. I hypothesize that some of this is in part environmental exposures, of which microplastic will be the first candidate for this. And time and research is going to tell us how impactful. And I don't know that anyone knows yet how to clean our bodies from microplastic.
Microplastic, that is the new thing. But it's only because I think we've gotten so accustomed to the fact that there are chemicals for everything we're exposed to.
Mm-hmm.
We used to pull weeds in the garden.
Mm-hmm.
Now some service comes in and sprays all this plastic. There's a linkage, I think, between funding for things that are for the environment because they know that if that would expose some of the things that the chemical companies are doing to our environment.
Yeah, there's the comment is there's been an over reliance on chemical developments for things like, for example, weeds, managing weeds in the garden and others where we have a chemical for everything. It's the comment. And so perhaps we need to be reevaluating that. The conversation on pesticides has been around for a long time.
I have a neighbor who's analogous, totally different, is cell towers and the emissions for whatever they are, the waves out there, he thinks those induce neuropathies, and he feels bad whenever he gets near a cell tower, and he's probably right.
I can hear them.
Yeah.
Like, I hear something. It's a buzz. The closer I get, I'm like, I need to drive away from this.
So we're constantly exposed
Yeah,
to that.
there's plenty of things that's right. There are plenty of things we're being exposed. And so we bring that in society as usually as a development of improvements or something that we want to do or something we want to do better off or without or something. So we're thinking we're improving things, but not always we do the proper questioning of, how good or bad that's for us long term. In the short term, it may be helpful, but long term, what implication it has. And so I think this is where research comes into place. These are the very appropriate research question. Okay, you want the benefit of that, but is it really good for us after the first time you use it? Or should you just only use that new thing once, not every day, for the next 10 years? And so research can actually help us answer some of those questions. But we would have to have an interest in doing research on environmental effects, for example, which my understanding is one of the research areas that's getting cut down. So this is kind of a funny comment. The other day I was walking on the trail in Davis. I live in Davis, and there was a sign that said, please be prepared to share the trail with sheep and goats, which will be brought in with professional shepherds. And it is a way to manage weeds. So I guess they bring them through, they eat the weeds on the trail, so they don't have to actually put chemicals on the trail. So it's kind of like a organic way of kind of reducing the weeds on the edges of the trail, which I thought was kind of interesting. Yeah.
American River does that too.
Mm-hmm.
Leaping back to Aggie Square, out of particular interest in there being a place to teach people plant-based eating and cooking. Because I think it's one thing to say, eat this. That does no good. It's make this.
Yeah.
And if you say, do this right, and then you can go across the street and get a nice greasy taco or whatever, a snow cone. Has your lesson been for naught? But if you show them how to make something that they will like and eat, and that to me was the weak spot in the rehab that I had when I was in the city. They were, this is quinoa. It's like, yeah. And how do you cook it? Well, this is quinoa. Like,
yeah.
No, I need more than I need delicious. And I'm concerned that we will be satisfied with identifying the good things and then pushing people out the door, and they will revert to what got them to come in the front door in the first place. So is there a place that teaches nutrition, not just serves as a cafeteria, or worse, does a little top-down sketch of this is the good life we want?
Question is there a good source of education within the health system for plant-based eating or healthier eating, which we should be teaching people not to eat, but how to make the food, if I understood correctly, what you were saying. That's a great point. There have been initiatives and programs that spring on their own. The one faculty member just basically started a program which became a virtual program. So it's mostly a website and videos and things like that. Physically speaking, I know of one program. There's a clinic, I think it's called Point West Clinic at UC Davis, which is by the Arden Mall, and they have an integrated medicine program over there, and I think they have a teaching kitchen there. We don't have anything in cardiovascular towards that. We used to with the old program with Dr. Capagoda. That has essentially been dissipated, and there are no plans at this point to bring that back, as far as I know. So I think there are some little fire initiative here and there. I don't think there's an institutional approach to this. I think the chef at the hospital actually believes in plant-based and local grown ingredients and adjust your menus for your season. So he does have very, very good insights and taking action actually. Now there is a plant-based option every day on the cafeteria. So I can eat plant-based every day now when I go to the clinic, because they will always have a meat base or chicken base and or fish, and then a plant-based option that complements each other. So there are certain things for the staff and employees. I don't think we have a comprehensive institutional approach to educating people on not just how to eat, but how to make, which I think is a great point.
Dr. Lopez?
Yes.
Yeah, the integrative medicine, they moved from there to Alhambra and Folsom.
Oh, didn't know that.
Yeah.
They don't send me every memo, you know. Thank you for clarifying that.
Okay.
I'm going next Monday. I'll see if they've got anything cooking.
Yeah. All right. Well, it's been fun. Thank you. I appreciate it. It's always fun to come and have this conversation.
Are you going a lot this summer? What's your summer looking like?
I will be gone in and out a lot, small little things, adventures, if you will. Yeah, we'll be doing some college touring for my son.
Is he graduating this year?
He's a junior right now. He'll be senior coming up. So,
Son, here?
yeah. So
I see now where he can take care of it.
yeah, he's challenging me. I don't have the hair I used to have. I'm trying to keep up with him. Yeah. So we'll be doing some of that. My one daughter in New York is gonna have to move, so some of my traveling for the summer will be to help her move out of New York.
Where's he going?
Well, we don't know yet. We know she's closing down in New York City, but we don't yet
Is that your
know.
oldest daughter or
Yeah.
no?
Yeah, oldest one. So she's still trying to figure it out, and they're adults now, right? So
Is Ella out of college or is she?
Ella is done at college. Yeah, she's actually living with us at home now. So, and looking how to get out, but still living with us. She's quite happy with it. So we're happy with it because she's the one that cooks, and she's learning how to cook plant-based. So we're starting to actually have her make some adventurous things plant-based at home. So
What's her degree?
her degree is in English writing. So yeah, she's an aspiring editor publishing company. So if anybody knows of where she can have an internship, she's currently looking. She's been turned down 300 places now. So yeah, so it's very hard to get into that field, that space. So, but she's top notch. But the last turn down she got, they said, "You are so good. We love your interview, this and that. So good that we want you to apply for the next job that we open up. Please keep us in mind." But on this one, we didn't take it. So, actually, I thought it was kind of one of the better ways to let people know that they didn't take you, was to kind of, point out that we kind of like what we saw, but this time we had someone else in line, not you. So.
My granddaughter graduated recently from Colorado and went for interviews, wanted to live in Nashville. And she had a good interview, but they were trying to hire somebody else. She sent them a thank you letter for the interview. They called her back and had another job for her in another department.
Yeah, no, that does happen. I told her just next, I know she sent the thank you. It said next month, just email them again and say, "Hey, listen, just checking in. What's your planning for the next 6 months on opportunities? Still looking," or let them know that you're still paying attention to them, to see what comes about. Yeah, I've seen that happening in our space as well. So. All right. Well, thank you, everyone.
Oh, thank you.
Yep.
Thank you.
Thank you for your attention.